Hi there. Welcome to the Healthy Enterprise Podcast. If you're a return listener, thank you for joining me once again. And if it's your first time, I hope you enjoy this episode. I'm going to be speaking with Laurence Bauer. He is a veteran leader in family medicine education and primary care workforce development. He served as CEO of the Family Medicine Education Consortium, promoting collaboration among academic and primary care communities. Now he's working as an independent consultant and remains committed to advancing a primary care driven system in the U.S. Please welcome Laurence Bauer. Larry, welcome. Nice to have you on this episode. And I'm looking forward to hearing about your professional career in your field. And so maybe that's a good place to start. Why don't you do a little bit of an introduction of yourself
Sure.
to listeners? And let's start with that.
Okay. Well, I'm a social worker by training and a weird social worker at that. So I started off many, many years ago and I did traditional social work things. I did family therapy, I did some community organizing. I actually worked in prisons for a while until I stumbled into a job at Penn State Medical Center in their Department of Family and Community Medicine. And I discovered that I really enjoyed working with physicians and I enjoyed working in healthcare. And my skill set actually is well aligned with the work of an effective primary care physician. So I spent a lot of time teaching mostly family practice residents, but also other residents, basic interpersonal skills, office counseling skills, and then over time I got involved in what you might call organized medical education, and let's see, I went from Penn State to Ohio State to Wright State University in Dayton, Ohio, and then after getting fired a second time and deciding that I did not like that experience, I decided to focus my attention on growing something called the Family Medicine Education Consortium, which is a not for profit that focused on supporting family docs in the Northeast region of the country, from Ohio to Maine to Virginia to West Virginia. And I really enjoyed, we ran an annual meeting, a 3-day meeting of about 1,000 participants, 300 medical students, 200 family practice residents, and another 300 family physician faculty. And along the way in 2008, I created something called the Innovators Network. I noticed that there was a lot of innovation going on in primary care, mostly below the radar. It was all local, people coming up with solutions because they were frustrated with the the care delivery system. And so I began inviting those innovators uh, to come to a meeting that was held the day before our big annual meeting. And we showcased the work that they did. And all these years, I still continue, even though I'm no longer running the FMEC, I am still running the Innovators Network for them. And it is one of the blessings of my career to uh, get to hang out with these brilliant people who are doing things to improve the health of people in their communities. And so that opened up a whole series of opportunities. So if you heard about direct primary care, I found direct primary care during our first Innovators Network meeting in 2008. We invited some of the innovators to come and share what they were doing. And that was so well received that led to the first Direct Primary Care National Summit, which was held in 2013 in St. Louis. And we had 176 mostly family physicians, come to the event. And each of them had thought they'd come up with this brilliant idea on their own. But it turns out they were part of a movement. that was in reaction to the um, third party control of primary care, the insurance industry and the hospital industry. So just this past weekend, I was in New Orleans for the Direct Primary Care National Summit, which has continued on, and there were 560, mostly family physicians, and it
Amazing.
was just a
Wow.
joy to see how that grew. So, I've had a chance to be involved in all kinds of projects that you wouldn't expect a social worker to be involved in, but I'm just a
Yeah.
curious guy and I love adventure. So um, I stick my nose in and I look for innovation, and I'm a connector. If you appreciate what Malcolm Gladwell wrote about in Tipping Point, and
Yes,
I've
absolutely. Very
uh,
familiar.
I've gotten to know a lot of people, and it's really, as I say, been a blessing for me to hang out with these folks. They're just a really great gang of people to hang with.
It's funny, and you wouldn't normally associate innovation with this group of people either. But it's interesting what you're saying. Is that what are some other examples of some of this innovation that you've witnessed?
So, in addition to direct primary care, the latest growth in that particular area is something called a community owned health plan, which is a
Hmm.
direct primary care practice plus a patient navigator plus a community owned pharmacy plus a healthcare architect who is putting the program together. It's a community based program. It helps small to medium sized employers uh, have coverage for their employees, and it's reducing the cost of health insurance 20 to 30% in the first year. It's
Is that right?
dramatically effective. Let's see other innovations that I've been associated with. Um, there's family docs who've developed their own electronic medical records. Um, some of which have gone on to great things in the marketplace. We had family physicians who uh, have launched. There's an organization called Primary Care for All Americans, and I'm on the board of that. One of the founding board members. It is helping people in cities, towns, and at the state level to form chapters of people who are interested in advocating for strengthening primary care. Um, that's been a very interesting project. They now have about 1,500 members across the United States. There's another project called Pulse Stories from the Heart of Medicine, which is a family doc and his wife. They are the editors of Pulse. And if you subscribe to Pulse every Friday, you get a well written piece of prose or poetry that shows up in your inbox. These are all
Oh, really?
stories from physicians, nurses, patients about the experience of giving and receiving care. Let's see what else.
Very interesting. Wow, that is quite a collection. I mean, just in just in that short few minutes, you've defined quite a few very innovative approaches to resolving some key problems. I mean, these are the people that are 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 they're in the trenches. I mean, they're the ones
Yes,
that identify where the hiccups are and where the gaps are, aren't they?
e- exactly right. So, family docs and the people who work with family docs are really focused at the community level. And it's the entry point into the healthcare system for people who are smart enough to have a family physician for their personal care. And they see things that clinical issues, ethical issues, health system delivery issues that the people at the policy level really don't see because they're too far away from where things begin. So, for example, you take the issue of waste in healthcare, and uh, about, according to most estimates, anywhere from 30 to 50% of the money spent on healthcare in the United States is wasted. And the question is, where does that waste come from? What exactly does that mean it's wasted? Well, it turns out if you move away from those big numbers, which are in the multiple hundreds of billions of dollars, and you go back to the leading indicators and identify the things that create the conditions that lead to the waste, you will find out that one of the biggest things is people not having a primary care clinician for their health care. So they end up with uncoordinated care. They bounce through the system. They get a lot of unnecessary tests. And some of those unnecessary tests lead to some bad outcomes that all could have been prevented had they had somebody who could quarterback their care, somebody where there was a trusted relationship with that person. So,
And what are some of the reasons why someone wouldn't have a primary care?
well, there's actually a lot of reasons. The biggest reason is they don't really appreciate or understand how the healthcare system works. So, for many people, they think that more care is better care. So, if I have an ankle sprain, I need an MRI. Well, probably you actually don't need an MRI. And
Hmm.
so that, you know, gets into some very expensive things. Sometimes it's what I call a cultural issue. People just believe, they believe that prime family physicians are sore throats and runny noses.
Hmm.
And I have a serious problem, and they think they need quote the best doctor, and they don't understand that the generalist at the front door is actually the best doctor until someone figures out what the nature of your problem is. And when you
Hmm.
go into an uncoordinated system, very likely you're going to bounce from one, what I call ologist, to another ologist, to another ologist. And along the way, one of them is going to do a test, and one out of every five tests that are done finds something that's a problem. Now, it
Right.
might be a real problem or it might be a false positive. And if it's a false positive, they're going to do some more tests. And
Hmm.
sometimes those tests lead to procedures. And I hate to say this, but sometimes those procedures aren't good for you. And they produce what's called iatrogenic illness, or illness caused by the medical intervention. And
Right.
now you're
Right.
going to be treating that. So that whole cascade, it's called,
Right. Just a
gets
waterfall. Yeah.
exactly. And so, what's the best antidote to that? To have somebody who you trust, who you can say, "Look, doc, this is what's going on with me," and they're skilled not only to look at what you might think of as the physical symptoms, but also sometimes our symptoms are caused by what's going on in our brain. Our anxiousness, for example, may cause the
Right.
symptoms. And you really want somebody who's trained to think what we call the biopsychosocial model, looking at the
Hmm.
big picture. So those are some of the things that could be going on.
Whereas, when you talk about a primary care doctor, somebody that you have as your doctor, who may, in some such scenarios, has known you all your life. If you have a family doctor who has been a part of a family unit, knows the family, knows the parents, knows the kids, is familiar with their environment, and has some an insight into their lifestyle and all those things that you mentioned, the triple threat or the triple connection between your mental state, your emotional state, your physical state, your environment. um, is that at what point did we start to detach from having the family doctor?
That's a very interesting question. So I'm knowledgeable about the history of medicine. And it actually started back in about 1915 when a guy by the name of Abraham Flexner wrote a report that argued that doctors are really should be scientists. We don't want doctors who aren't scientific in their orientation. And
Mm,
so the generalist, he thought the generalist was somebody who needed to go away. So, beginning with his report and the re engineering of our medical schools back in that day, it continued for, for decades. We got into the post World War II era and the growth of the medical specialties. Every time somebody develop a new procedure, they develop a new medical specialty. So when they learned how to put a scope into various parts of your bodies, they invented new specialties to do that. And
mm,
of course, those new specialties argued that their particular expertise was much more complex than that of the general practitioner. So they should be paid more. So when
right.
they got that built into um, the codes that govern Medicare, for example, all of a sudden the medical specialty started making a lot more money than the generalist, both the family physicians, the general internists, and general pediatricians. And over the decades, the last 50 years, that uh, divergence in income has grown dramatically. So
Mm,
there is a great deal currently in our healthcare system that argues against what you might call generalist careers in medicine, even though
mm.
there's some very good research that shows the generalist, for somebody with no symptoms coming in the door, you really want the generalist first so you can sort out what needs to be done and then get you to the right specialist down the road as opposed to the random specialist that you might pick as a patient.
And then, that there's a continuous collaboration after that point. Your general will
Yes.
communicate with the specialist, and then the specialist will communicate with the general. And now you've got two people kind of looking out for your interests, right? Is
Well, that would be ideal. Our payment system doesn't support that very well at all.
Right. Right. Yes. Um, and another layer to this onion is maybe accessibility too, to,
Yes.
whether it's remote, less access to general practitioners in rural communities, things like that, or just a lack of general practitioners.
Well, yeah, it's more the lack of. So, rural America is about 25% of our population. And currently, and for quite some time, family physicians are overwhelmingly the predominant medical specialty that's serving the rural population. But our medical
Yeah.
schools, for quite some time, have been underperforming in terms, not
Mm.
only in terms of graduating people to generalist careers, but also
Hmm.
people who are going to go and serve in rural communities. So there is a currently um, an underwhelming number in the rural communities, and of course in our urban areas. So within the woman by the pediatric epidemiologist by the name of Barbara Starfield, back in the 90s, did some research, and she found out that any community that has that adds family physicians in particular, or primary care clinicians to their practitioner group, there's an increase in health in the population and a decrease in
Is that
cost.
right?
The more
Huh.
subspecialists that you add, the more expensive, and the death rate increases. So,
Is that right?
those are the
Wow.
kind of things that people generally don't know. So, they don't appreciate
Yeah.
what I call the promise of primary care.
And so we have now, so now we have this shortage of family physicians, um, and maybe there's more of a draw to the specialties because it's shinier, it makes more money, higher status,
You
those
got
kinds of
it.
carrots.
Those are the big three. Yep.
Yeah. So
There's
now,
one other,
some,
Keith. There's one other issue that factors into this that people don't think about.
okay.
So currently, if you look at medical students, who's getting into our medical schools, the overwhelming, and I'm talking like 75% of the kids getting into medical schools today are from families of wealth.
Ah,
Okay, they get to go to the right kind of school, they get the right kind of education,
right.
they get the right kind of life experiences, so they are far more competitive. And the schools are looking for kids who are really good test takers. Even though they say they no longer use those, they still, in their interviewing process, have a bias towards that. So in the kids getting in who are likely to choose a primary care, be that general internal medicine or general pediatrics, there's just not enough of them getting in. And people think it's about the money, and in part it is about the money. But if you didn't have the wealthy kids getting in, they are very oriented towards making more money than mommy and daddy. The kids
Right.
who are first generation to college, the kids who are from rural areas, um, the kids who have been out of college for a year or two, who get a little life experience and figure out what's really important in life. Overwhelming, they choose careers in primary care, but they're not able to get into the medical schools.
Interesting. Wow. That's a that's a situation for sure.
Yep, we've
How
got a real situation.
Wow. So now we have there's some other innovation coming that's been growing. It's been around for a long time, but telehealth, telemedicine,
Yep.
where you can get access to family physicians, generalists, uh, through that technology now too. Is that helping this a bit of this problem of accessibility at the very least?
So I think yes, it is helping with the accessibility issue. Um, it's it makes it easier for people to get a hold of somebody now. It's oftentimes it's not somebody. The last time that you called into this service, you're not getting the same person. You're getting a different
No,
person,
probably not. No.
which sort of undermines the continuity, which is really important because through the continuity, somebody gets to know you. They get to know your style. They get to know your
Mm-hmm.
your biases and your issues, so to speak, and they can put things in perspective about a problem. So they may not need to do testing to answer a diagnostic question because they know that you're the kind of person. You're hypochondriacal. You're somebody who gets anxious easily, and you've got a symptom that could
Mm-hmm.
very well be because of a fear, call it, that you may have, that you may not even know that you have. But
Mm-hmm.
so at any rate, I think it's a good thing. I think what's even best is if the doctor that you see regularly, you're able to reach on the phone or via
Mm-hmm.
secure Zoom or whatever. That would be
Mm-hmm.
ideal. But quite honestly, we don't have enough people in primary care right now to
Right.
be able to pull that off.
Right. That's the main thing is the shortage
Yes,
of actual
absolutely.
caregivers. Yeah. Yeah. Interesting.
I think you have
All
some of that
right.
going on in Canada as well.
Absolutely. Yeah, 100%. Same thing, same problem here. It's difficult to find a family physician, but it's also it, although the importance of having the importance of having a family physician here is very, that's still quite high. It's like it's very
Yes.
important issue in a lot of people's lives. Like, I need to get a family physician. I don't have access to one. And you know, it's not for lack of wanting it. It's like they want family physicians. We just don't
Right.
have enough either. We're recruiting all over the world to bring them in to supply that, to supply the demand.
Right. Exactly.
You can't get and I guess our system holds is a little different too, is that you can't get anything done without a referral from your family physician.
Well,
I mean, you
that's
can if
one
you
of
go to the
those.
emergency.
Yeah.
If you go to emergency, sure, yeah, they'll say, okay, yeah, you got a problem. We're gonna connect you with the hematologist, or we're gonna connect you with the oncologist, or whatever it is. But for the most part, you can't get it if you got even a skin issue or a rash or something. You need to see a dermatologist, or you got to get a referral from a doctor.
Right. Right.
So that causes that problem, is that's why we need family physicians all the time, because they're the ones, they provide the distribution channel with the referrals.
Well, yes, and they're doing that because challenge. So there was a company in Dayton, Ohio, Mead Data Central, it was called, and they put a health plan in, and they incentivized their employees to choose this health plan for their health insurance. And the way the plan worked is you could go to any subspecialist you wanted to, but before you went to the subspecialist, you had to go to your primary care clinician, be that a family physician or general internist. And once you went to them, you without a referral, you could go to wherever you wanted to go. And what they
Mm,
found is that for most people, for most of the problems, the family physician was able to clarify the problem, deal with the problem, and the patient was satisfied. And they thought they needed a subspecialist, but actually they didn't. It's simply a matter
right.
of them not understanding how medical problem solving works and the power of a
Hmm.
generalist.
Yeah. Yeah, I think it's yeah, very important. I guess there's a we're also looking at, from my understanding, is looking at other levels of care, either from pharmacists, for example, who are
Sure.
now starting to be able to prescribe certain medicines and drugs for certain conditions or issues. Registered nurses who are able to actually treat people for certain levels of care, and that as well, which is, I guess, sort of serving this same concept, is that they're generous in that sense.
So I wouldn't use the term generalist. They are certainly, skilled within
Sure.
their training, their scope of practice, so to speak. Um, the best care is what I would call team care. And so if
Yeah.
you have a pharmacist, if you have a nurse practitioner, a physician assistant working with a physician, the outcomes are much better. If you have those folks practicing independently, and I know people will get upset with me for saying this, but when they're practicing independently, the referral rates are so much higher. And going back to what I said earlier, if somebody ends up going to what I call an ologist unnecessarily, the rate of things happening that aren't in the patient's best interest goes up. People don't want to report that, but I mean that is the way it works. You can't learn how to deliver effective broad-based primary care with the amount of training that a nurse practitioner or a PA, but working together with the doc, that's a powerful team.
Yeah, that would be ideal. Yeah, to have that network all working on the same issues, and yeah. but we just need more people. Okay, let's
Yep.
talk about Primary Care Innovators Network now. Let's and your role with that. You're the CEO,
Yep, I am.
and so tell me a bit about when you now that you're doing that, the shift for you from when you were working in social work to that. Um, what was that change like for you, and what motivated you to do that?
So I realized now a long time ago that my goal really was to change the U.S. healthcare system. Our system is ineffective. In many cases, it's corrupt. Um, and I'm speaking about the U.S. healthcare system. And
Of course,
it is uh, tearing down our society. So if you were to ask the question, what is at the core issue for people in the United States who are working class and middle class, that they feel hopeless and frustrated and believe that there's no future for them, that they can't afford a home, that they can't afford a good education? What's at the core of that? At the core of that is the high cost of medical insurance. So it's been going up in the US by an average of 8% a year for decades. All of that money that's going in, it's ridiculous, really, how much money goes into employer sponsored healthcare. And if you could take 20 to 30% of that money today, this first year that you worked on an innovation or implemented an innovation, you could take that money out. What could you do with that? Now, that's a big number, 20 to 30% of 12 to $14,000 per year. So if you could take that money out, what could you do with it? Well, you could put it into wage increases so that people would have more disposable income and they could afford housing, food, education, etc. You could take some of that money, because it's so much, and you could invest it in housing. So we would truly have more affordable housing for the working class and the middle class. You could invest it in our educational systems so that, for example, pre K education was free across the country. You could invest it in what everyone talks about as the social determinants of health. So, the reason, in my opinion, in the US, that employers do not want to support a living wage increase, a reasonable salary, is because they have to keep investing money in the health insurance. And they means
it's
they
a huge
can't.
it's
Yeah,
a huge line item on their uh,
absolutely.
on in their financial department. Yeah, it's a huge item. Yeah,
So they can't put it into wages, so the wages don't go up. So if we're able to tame the beast, so to speak, then good things can happen in this country, and we can move away from a lot of um, the frustration and the hopelessness that some parts of our society are experiencing. And I decided that I wanted to be a part of that, and I was seeing these innovations out there that had such great promise. So I decided to focus my attention on finding the innovators. So there's something called the social diffusion curve. And people have heard these terms before, but you start off with the innovators. And within any group, I don't care if it's agriculture, manufacturing, technology, whatever, there's about 1.2% of the people who are involved in that domain who are the innovators. Those are the people who just they see solutions and they can't take it anymore. They got to go for it no matter what the risk is. These are the people who create the change. The next group are what are called early adopters. They're about 12.5% of a population. The early adopters are people who are looking for new ideas, but they're a little risk averse. So when they look over and they see the innovator doing something, they say, "Oh my God, look what that's, look what we could be doing here." And they, together with the innovators, begin the transformation process. And then you have the early majority, who are people who are not risk averse. They're not going to change until something's proven, and they can just apply it and do it. They're about 15% of the population. When a new innovation gets adopted by those three groups, it creates a tipping point, and the late majority people go, "Oh, okay, yeah, I guess I have to change. I'm not really crazy about change, but I need to move." And then the system changes, and then the laggards who are on the other side, the ones who say, "I'll never change. We don't need any of that change." They change because the whole thing changes around them, and they have no choice. So what I focused on is finding the innovators and creating opportunities for the innovators and the early adopters to meet and get connected and share ideas and begin to call it make deals, so that the free market forces, or the other ways of financing things can support the change process. So that's what the Primary Care Innovators Network does. And it's just so cool to see the solutions people come up with, and watch
Yeah,
how that transformation process happens. And I want to be right at the middle of that.
that's great. You have a real passion and enthusiasm for this, and I think you called yourself. You're very curious. You said
I
at the
am.
beginning, and that curiosity is what kind of drives you. And then, from your background, so how does your background and your education tie into this for you? Like, what is it about you and your character that is suits you for this role?
Well, because I am a curious person and I love adventure. You know, I love going off on a trip. I love coming home even more, but I love going off on a trip. And each one of these innovations that I find is kind of a trip, and I enjoy doing this. In terms of my training, so as a social worker, there are sort of three groups or three domains within the world of social work. One is the clinical one, which tends to be working with individuals and small groups and families, but doing therapeutic interventions. And I did that for a while. The next level is the community level and community organizing, and I did that for a little while in my career. And the third level is what people call policy, looking at the big picture and thinking about the call them the rules and the principles that need to put in place to create healthy systems. And I evolved through my career. I started off on more on the clinical side, and then on the community organizing side. And then when I got involved in medicine, I saw kind of a chance to put it all together, because the family docs, they take great care of people and communities. And by helping them be more effective with their work and their careers, I was multiplying my effects. So, a
Mm.
family doc might take care of a couple thousand patients. If I can help them learn some skills that make them better at delivering primary care, that multiplies the number of people that I'm able to touch. And every now and then, I think about all the family docs in particular that I've worked with over the years. And I don't actually do the math, but I just have to imagine, you know, that the impact that I've had, is so much larger than had I chosen to stay in my clinical practice, seeing a patient an hour or working with an individual family at a time. So, as I say, I've just come to believe we have to create healthy systems. And,
Hmm.
and that means the big picture, but it also means getting down to the delivery level to find the models that make for better care delivery, um, people, person by person, and within each community.
When you're talking about the skills that you were teaching these docs, give me an example of something that that you would teach them.
Sure. So one of the things I taught them was interpersonal skills. I was a trainee.
Bedside manner.
You could call it bedside manner. Yeah, a lot of people do, but
That's a common phrase. Yeah.
yeah, having effective skills and being able to communicate um, with a patient and with a family, how to hold a family meeting. I used to
Yeah.
teach them how to do a home visit, where you could go out into someone's home and work with usually the family who was present there. I also taught them um, problem solving skills in the in the behavioral health area, how to think about family systems. Um, so all of us grew up in families. Well, not all of us, but most of us grew up in families, and those families had what you might call a culture, and that culture influenced how we think. It influenced how we felt. It influenced the choices that we make in terms of a life partner, et cetera, et cetera.
So true.
So
Yeah.
how do
So true.
you understand that as a family physician? So there was a lot of things. One of the things that I did that I was very proud of is in family medicine. We started right at the beginning of the family medicine movement in residency training, something called a Balint group. So the residents, in the case that I worked with, the residents would get together once a week, and I would facilitate a discussion, and they would talk about being a doctor. They talk about their fears. They talk about their joys, their and their sorrows, and you know, becoming a physician is very hard work. It's hard physically. It's hard emotionally, and I just love these TV shows like ER and what's the other one I was watching?
Grey's Anatomy.
Yeah. Um, well, number one,
They're so true to life, aren't they?
well, except for the sex part. They just throw in a lot of gratuitous sex. I'm telling you, I've worked in 3 medical schools, and yeah, there was times when people got into things. Let's put it that way. But mostly it wasn't. Man, they were working very hard. They were tired, um, but it was so this resident support group process. They should have that in the middle of ER. They should have that in the middle of any of these intense resident training programs. So it's
it's it just
interesting.
it probably creates an ability for them to be, well, there's the compassionate edge which they probably already have, but also just an understanding of all the, that people come from different places, and where would they fit that into to medical school anyways, right? So
Yes.
this would be very valuable insight for them. I can just imagine that they probably had a lot of aha moments during their consulting with you.
Well, and the other thing is, if you think about the age of most first, second, and third year residents, they're relatively young people. they haven't had that much life experience, quite honestly.
No, exactly. You're right. They spent most of their time in school.
Exactly. So they're starting to sort through some issues in their
Mm-hmm.
life, and sometimes that can create tension points in their ability
Yeah.
to take care of patients or their ability to deal with authority figures like faculty. So it was that was one of the most satisfying things I did was for a whole year I would have the first year residents, and every Wednesday we would get together for an hour and a half, and they had to turn their pagers in. It was covered by a secretary, and the chief resident and I would lead this discussion group, and it just we covered everything that you can possibly think of.
Very, very interesting. Wow. What an yeah, what a cool niche you found, and
I just stumbled
a way
into it.
to share. Oh, I don't know. I think you probably were drawn into it. Yeah.
Yeah, I think so.
Yeah,
Yeah, it aligned very well with my curiosity and my need for adventure.
absolutely. Absolutely. Well, and this has been very interesting, Larry, to share this with me. I wasn't sure what I was going to learn, but this has been very cool. I really
Oh, good.
appreciated you sharing and spending this time with me. So, with innovators, people who are out there who are working in the industry are, like you said, people are coming up with ideas. They're finding, cracks in in their work or in their environments. And so if they have these innovative ideas, um, the best thing for them to do is sort of reach out to someone like yourself or to the organization so that they can find out that, yay, maybe someone else has already come up with an idea and they're already starting to work on it and they can contribute to that, or at least understand that they're not the only one that has this problem and that there are ways to work together to come up with solutions. So
Yes,
is that who needs to reach out to you if that's where they're at?
absolutely. The other group of people are the ones who know about an innovation. I get referrals, if you like, where somebody will
Mm-hmm.
contact me and say, Larry, I think you need to meet so and so because this is what they're doing that's different. And I I'm just one person, and I try my best to do a lot of reading and a lot of meeting. I like to go to conferences and hear new ideas and walk through the exhibit hall looking for new ideas. But I'm just one person, so having call it a referral. I don't have a formal process, but having somebody contact me like that. Um, is very it's just a great opportunity.
Well, if someone wants to reach out to you, what's the best way to track you down?
So my email address is the simplest. It's Laurence, Laurence dot B as in brother, AUER at gmail.com. And I'm pretty good at keeping up with my email.
Okay, and you're on LinkedIn, so they
I
could
am
probably
on
find you
LinkedIn,
there as
yes,
well.
and Facebook.
Yeah.
And Facebook.
Okay. All right. Well, what a wonderful conversation. Thank you for sharing your time with me. Is there any last thoughts or comments you'd like to close with?
I don't think so. I think I've probably said enough already.
Well, thank you so much for sharing your time with me. I appreciate it immensely. Okay, well, that wraps up this episode, and I really appreciate Larry for joining me today and sharing such a rich and thoughtful perspective on the state and future of primary care. There's a lot there that I didn't know about, and what really stood out to me about this conversation was just how foundational family physicians are to the health of communities. I was also struck by Lawrence's reminder that innovation in healthcare isn't always about technology. It's sometimes about trust and relationships and just meeting people where they're at. Lawrence spoke about this need to teach interpersonal skills to physician, which was also really interesting and a powerful takeaway. It's a reminder that healthcare at its core is human work. And if the system is going to improve, it's going to have to start with connection. Thank you for tuning in. And if you found this episode interesting or insightful, then please share it with someone and subscribe for future episodes. Until next time, take care and stay healthy.